It's a pleasure for me to take this time and introduce Mike Bahr. I remember years and years ago, man, it must have been 25 plus years ago, Mike was just back from his mission. He served a mission in Idaho. He's from Atlanta, Georgia. And he was in my class. When he stands up, you'll notice that he's tall. He's 6'7" and stuff. And so it was easy for me to spot. He was still trying to sort out what career he should do, and I gave him some advice. I'm sure a lot of other people have given him some advice, and I know he's been very successful. Let me just go through a couple of things about Mike. First of all, he graduated from BYU in 1986, I think, and he got his master's degree in 1987 in statistics with an emphasis in actuarial science. He then went to work for CM Alliance Company in Hartford, Connecticut, as an actuary, and then from there he moved to Time Insurance in Wisconsin. Then in 1990 he came back to Utah and started to work for IHC. Some of you will be familiar with IHC's health plans. And in the next 10 years, while he worked up, he became Vice President and Chief Actuary of IHC. In 2000, he left IHC and went to work for Altius. I don't know if any of you are driving up the highway here and you see the big building that says Altius there. Yeah, that's where he was. He was the president and CEO of Altius. Now, for those of you who know anything about actuaries, need to recognize that though actuaries are intimately involved in insurance and in consulting, very rarely does an actuary ever become the president of a company. I don't know why that is, and I think Mike can tell us why it is. But they are usually an executive, but not the president. So this is quite an accomplishment. And then he made Altius profitable. And because it became profitable, it became acquired. And so it was acquired by Coventry Health, and he joined the Coventry Health organization, which is one of the bigger insurance companies, I think 8th, isn't it, or something like that? 7th, okay, sorry. And then in 2009, he became Executive Vice President in charge of all their commercial business at Coventry. It's ranked number 212 in the Fortune 500 list. He's published in the Journal of Risk and Insurance and Proceedings of the American Statistical Association. He's been a consultant with and on the committees appointed by Governor Mike Leavitt and Governor John Huntsman with regard to health and health care. I know he's been involved in aspects of COBRA and how do you insure the uninsured and stuff like this. In fact, I remember him talking to me about the nightmare of trying to figure out what that was. He's active in the church and various church callings from state clerk down to, I don't note here that he's been a scoutmaster, but I know he's worked with a lot with youth. I don't camp. Yeah, I don't camp either, but I got stuck anyway being there. Oh, no, I came out incorrect. Sorry. Oh, and my state president. Continuing on here. He is currently living in Maryland, although he retains a home here in Highland. His wife, Tammy, who's in the back, and he have 5 children, and I think they have 6 grandchildren. I remember one day when Mike, on a personal note, came to my office. He's a big guy, and so he took most of the doorway. He stood in the door, and he sort of indicated he wanted to work with me on a project. And I said, well, tell me about your qualifications. Why would I be interested in having you work on a project? And his statement is unique. I've only heard this once from him. Just 3 words. If any of you students can say the same 3 words and live up to them, which he did, you'll be a very valuable person in business and very valuable in your research career. His 3 words to qualify him were, I meet deadlines. And through the whole time that we worked together, even though some of his deadlines required him to stay up 2 or 3 nights in a row doing all the computing, he did meet deadlines. And I would suggest that he is a bright person, he's very capable and hardworking, and this meeting deadlines is possibly one of the secrets to his great success. Let's welcome Mike Bahr as our
Thank you, Dennis. Dr. Tolley. Let me get this straightened out here, and we'll. A couple things. I I tend to walk when I talk and present, and I've presented to some really large groups on different things related to health reform or insurance, and I always try and make them interesting. We're going to talk today a little bit about health insurance, some of the things that are in it, and I'm going to keep this interesting. So those of you who are kind of like, I don't know anything about health insurance, we're going to make it interesting. Some of the things that are in the bill that are going to create problems and kind of where that goes from an actuarial perspective, what happens to the actuarial field in the current reform model. As I talk about that, let me give you a little story. I went, my first job out of BYU was in Connecticut, and I showed up for my first day of work, packed up the 3 kids, my wife, we went out there. I was all excited. I went in, first day of work, came home a little depressed. Tammy goes, "What's wrong?" And I said, "Honey, it's true. They're all nerds, every single one of them." And she said, "Honey, you're going to fit right in." So some of you are trying to figure out if you have what it takes to be an actuary. I'm going to help you with that because I'm going to ask you certain questions that you might be an actuary if, and that's going to keep this a little entertaining. So we're going to start with, do I point it here? Here? You might be an actuary if you hear a joke on Monday and start laughing about it on Tuesday. Those of you who are older, this may help you with your kids, if you have kids trying to figure out what they want to do for a living. You can't have a discussion about health reform without talking a little bit about 1997's health reform. There was significant reform in 97, which you haven't heard about at all in the discussion about reform today. That reform is actuarially sound. And when we go through these things and I talk about actuarially sound means it survives a long-term risk analysis where you can price it and it will be solvent down the road. Health reform there, a Republican House and Senate and a Democratic president said, we've got to change health care. So they went and made some changes. The big ones, a couple of big ones is all we're going to talk about to set the table here. One is pre-existing conditions. If you had coverage, you were insured, and you left your job, you were guaranteed issue coverage without pre-existing conditions. So just the very nature of that statement and how it's defined means pre-existing conditions that don't exist for people who have coverage. It was designed so that if you did not have coverage, you chose to not purchase it, and then got sick, you couldn't buy it because other people who've been paying in and managing that risk, they'd already been paying in and you were basically leveraging them. That was the definition. A couple of other parts is they modified rates. A small employer business was guarantee issue. You had to insure small employers. And they left it to the states to define how they wanted to do that with a guideline from the NAIC, the National Association of Insurance Commissioners. That guideline was you're going to set an index rate and you're going to have bands around those rates. And that index rate, this is going to end up being a problem for me, isn't it? This one? The trigger. Okay. I guess it won't be a problem. The problem's me. So what you did as a carrier is you filed an index rate, and then in every state, they defined the range. So a healthy group that you evaluated the risk on came in, you could rate them down here, and a sick group here. Even if their claims were way up here, they were guaranteed issue a rate here. States like Florida said, you know what, we're going to do the index rate plus or minus 15%. States like Utah said index plus or minus 30. The NAIC model was plus or minus 25. That's the most common. So all groups get coverage. They get medically underwritten, the belief being they have some responsibility for the health of their employees, and one of the biggest drivers of where your costs fit in this spectrum, particularly when you're talking about groups over 20 employees, is your participation rate. How many employees participate in your plan? If as a carrier you contribute more to their insurance, more participate. I did a paper, I presented to the Society of Actuaries, and this is like early 90s, showing that if you have high participation rates, your medical costs end up down here. If they're low, you end up here. So you're having the employer pay part of that. The second piece of this is the selection curve for individual. You medically underwrite individual. You know they're healthy. So they're coming in at a very low cost. Over a 10-year period, these are years, they end up relative up where the average cost for a person is. So they're getting a low premium. States had to figure out how to deal with that. Some states said, you know what, everything's going to get rated here, and we're going to have it be the same. Most states recognize that a lower premium initially, premiums down in this range, are going to get more people insured. So they created what Utah did, which was a high-risk pool. If you came out of the group market, you were guarantee issue, you got coverage, then basically you were in a high-risk pool paying here, subsidized by the state. Everybody else, my kids in the back, when they went out and bought, they're paying somewhere around $150 because they're relatively healthy and they met through underwriting. And then states set guidelines of at what level they go to this risk pool. So it's actuarially sound, it survives long-term test, kept premiums low. I need you to understand that as we talk about this new law and the impact it'll have. So you might be an actuary if, after taking a course in heredity, you write a paper providing conclusive proof that if your parents didn't have children, you probably won't either. So second thing you have to understand as we talk about this is health claims cost. I do this when I talk about medical trends. If food were health care, trending from 1930, a dozen oranges would cost $107 today. That's how much health care has gone up. Same thing's true if you look at these, a pound of bacon, $122. The difference is in health care, it's not the same pig. We have technology today that significantly enhances lifestyle and significantly extends life. If you go back to 1930, the average life expectancy in this country was around 60. You look today and you're pushing 80. Where does that spending go? When I moved to Utah in 1990, we spent basically less than 3% on pharmacy costs. None of the drugs that are out there today were available. You didn't have Lipitors. You didn't have a lot of the statins. You didn't have the biologics. If you have MS or rheumatoid arthritis, you can get an injectable medication today for just over about $1,500 a month that for a high percent of the people that have it will eliminate those symptoms. That all costs money, and that's all in this 14% of cost is pharmacy. The second big one's outpatient. Outpatient cost, by the way, the MS, the Enbrel, doesn't cure it. You have to have it every week for the rest of your life, but you're in that position. Pompeii's disease, which is a rare disease, it's about $100,000 a year for the rest of your life. Those are expensive medications. Outpatient, things like stents have reduced heart attack deaths significantly. They've reduced open heart surgery. All those things enhance our quality of life. They're all in the cost. So when we can't compare medical trend to bacon, you could probably compare the amount of bacon we eat today compared to 1930 maybe and say that went up 100%. Second thing to understand is the cost curve. We're an aging population. Costs are significantly more for people who are older. Now, I didn't have a problem with this until I hit about 45, but now I have Lipitor. So basically, under 25, if the average block is 100%, under 25, you cost about 45% of what your average premium is. By the time you get in your 60s, you're 7 times higher. So you have a couple things you're dealing with as a society, an aging population, and when you talk about medical trend, if medical cost is going up 7% a year, where's it going up? It's not going up here. They're not using any new technology. It's the chronic conditions that we all pick up here. The hip replacements, the knee replacements, the heart treatments, all those things are on the high end. So when we get into what's going on with reform, you need to understand, remember this curve. It's going to show up again. Second part is the dollars. Where do the claim dollars go? Basically, 20% of the population has none in a year. Zero use of the system. And this is the average claim. Over 80% of the population is below average. And a better chart to show that, in the United States, 5% of the population make up 52% of the healthcare dollar. So when we talk about what's called an adjusted community rate, everybody kind of paying the same, remember, 5% of the population, 52% of the dollar, 50% of the population makes up 3% of healthcare costs in the entire country. That's a huge discrepancy. And it's what you have to address for, because you have to create a product that keeps those other 50% in and gets enough money out of them to pay for these, because this is where all the use is. You might be an actuary if you would rather be completely wrong than approximately right. I posed for that picture. prior to my spa treatment. So here's what the administration wanted to do in reform. Coverage and insurance market reform. We want to make it more accessible and affordable for all individuals. As we go through this, you'll find out they didn't do this one. They did do this one. We want a delivery and payment system reform that pays for quality. That's something the industry's been arguing for years, and give the administration credit to build it in. We have too many insurers whose whole job is to pay claims, and they aren't doing anything to improve the outcomes and the status of the member. This bill has pieces in it that do that. And financing strategy, the strategy here is interesting because what they're going to do is charge more to those who have insurance to subsidize other people who have insurance, and that's not a long-term solution. But that's right now the insurance companies are paying a higher tax, as are Medicare recipients. So the implementation, really quick, this stuff's all implemented. Nothing over here is not actuarially sound except this piece, and most carriers pulled out of offering children-only policies because of that. Because children can, when they get sick, their parents could enroll them with no pre-existing conditions. So you have to have coverage or it doesn't happen. We're going to focus on minimum loss ratio requirements in the market today, and then the big piece over here, exchanges with the guarantee issue renewability and the rating limits, because that's the thing that's going to have the biggest impact on what is going on with insurance in the future and the actuarial role, because frankly, half of what actuaries do today goes away in this. So these are the ones we're going to talk about. An adjusted community rate, what that means is everybody gets the same rate with an adjustment for age. That's it. So if everybody gets the same rate with an adjustment for age, then you end up with a model similar to what Massachusetts has. The bronze, silver, gold, platinum plans are the plans defined by the administration. You go in the exchange with 4 plans at most. And they define the benefit design. So you're all selling something very similar. And the way it's going to work is the consumer's going to go to a website. They're going to get all the information, the quality information, things like that on the plan. And then they're going to go and they're going to enter their income. They're going to enter their marital status, number of kids, and it's going to route them electronically. If you qualify for Medicaid, it routes you to Medicaid. If you qualify for the exchange, it routes you to the exchange, and all the plans you can choose from are there. So it's a much simpler distribution model than what's there today. Now, we have this today. Companies like eHealth Insurance, about 25% of our individual policies come from them, but they don't do the Medicaid piece, and they don't carry the federal. If you make less than 400% of poverty, you get a federal contribution. So this will have that built in, and it's cheaper than using insurance agents, things like that, to sell individual. And I think that was the intent, was to come up with a way where the distribution model was better. CBO projects, this is, and these numbers are wrong, but this is what they project. So let me clarify that. Basically, 50 million uninsured is going to go to 22, and the non-group exchanges, which is where the community rating has its biggest impact, and groups under 50, is going to go to 31 million people in 2016. And the real numbers that we'll stand by are these, which are basically by 2000, and that should be 16, you're going to have 56 million people in the exchange. Now, the scary part, and these numbers, we came up with these on our own, but if you look at the McKinsey study and the RAND study, they're pretty similar. They end up in the same place. So the problem, though, is this is funded at the lower number. And the federal government's subsidizing the premiums for a significant portion of these people. And so if they're subsidizing the premiums, then, and there's 25 million more people in that exchange than they expected, that's going to cost more money, and they're underfunded, probably by about $1 trillion over 10 years. The second piece of this is what happens to the small group segment. I've talked to lots of small group arenas with hundreds of group owners there, and I can tell you I'm not even sure there'll be 13 million left in small group. And I'll show you why. So, number 7, you might be an actuary if you like to have fun only when nobody's watching. So, I'm not going to read this, and it's in the presentation if anybody needs it. Here's kind of the layout of the things they've decided. There's nothing in here. They're going to allow the states to establish area factors, which is charges by different regions and things. But the open issues, are the ones that are out there that are going to have a huge impact. How often do plans get to change rates in an exchange environment? Do they require auto-enrollment processes and the standards and metrics we use? So as a company, we're trying to plan for something that we don't control. Then the scary part for us, and we're in a lot of states, we've got about $13 billion in revenue, and dental, other stuff, not just health. But if you look at this, you've got states like California that say our governing board for the exchange, the group that's going to set our rules, is going to be made up of members that may or not represent health plans or providers. Today, there's not one health plan representative on there. And so they're telling the carriers, yep, you're going to assume the risk, and we're going to set the rules, and by the way, we'll figure the rules out on the fly. West Virginia, same thing. You've got 10 people on the board, one person representing a health plan. So for us, we get really nervous when we start looking at other people telling us what we're going to do with our money and what our liability is. If you miss, I'll show you later on the risk selection stuff, if you miss how you set that up, I mean, a company could go in with $1 billion in premium and lose $500 million on top of that. And so it gets a little scary when you're an insurer and you're trying to figure out how you're going to work with the states and how quickly people are trying to implement this. You might be an actuary if you are so dull the accountant's notice. I've got 2 sons that are accountants. And I do view them as social. The second one here is the shop exchange. Now, the shop exchange is for employers. And the employer exchange, I met with Rex Cowdery, who's with HHS and in charge of setting the rules for this. And he asked us, so how do we make this work? And I walked him through why you can't unless you change the law. We know some things are going to have to change in the law for it to be viable anyway. But if you take this structure, they're basically dooming themselves to failure in this shop exchange, which is supposed to cover employers, depending on the state, 100 and under or 50 under. And the reason that's going to go, I'll show you why that's going to happen in a minute. And they've got similar open issues as the other one. The shop exchanges aren't structured the same way with the same committees. The states work with the carriers on that one. You might be an actuary if, when asked by a beautiful woman for your phone number, you give her the number plus or minus 10%. I had a different one in there, but I didn't know if you guys at BYU would want it. So it was you want a wife and a mistress so you can tell each one you're with the other and then go to the office and work was what it was. Changes resulting from adjusted community rating. So you've kind of seen the layout of reform and what's going to happen there. What's community rating going to do? Okay, today they've defined 3-to-1 age bands. No state does 3-to-1 age bands. So right off the bat, you can see you have a problem. The younger, healthiest people, their costs are going to go up, double basically, so that those above 55 can get subsidized. So that creates 2 problems in the open market. Most of the uninsured are these people, and you're raising their cost. They don't want to pay $150, and now you're telling them it's going to be $250 or $300. The second part is most of these over 50, a high percent of those people are early retirees with companies like Caterpillar, John Deere, and they're funded by the union plan. Now, the union plan is paying their cost up here. So what's the union plan going to do for early retirees when they find out they can go into the exchange and save 35%? They're going to send them to the exchange and save 35%. It's a guarantee issue. Then this whole curve goes up, and these people down here are now paying up here. And so you've created an adjusted community rate with a 3-to-1 age band that's too steep relative to what reality is in the market. So you're going to create the younger students, those of you that are under 30, 35, are going to look at this and you're going to have to decide, am I going to pay that much more to get coverage, or am I going to gamble and go without? And that's why the penalty became such an important part of getting everybody in the pool. This only works if you have everybody in the pool and they can't get out. But today, the penalty is going to be quite weak and may even get struck down in the courts. As I read the court case, I think that part probably will. So what happens as these people leave, then the rates out here continue going up, and you create a claim spiral or a death spiral on claims. And there's no way to get around it unless you can get the younger people back in the population. Second part is you're eliminating the underwriting, so the underwriting curve goes as well. And so that part's going to be gone. So people today who are paying $150 for their health care are going to be paying $350 for their health care. This was pointed out to Obama after it passed, and he said it's okay, that's why we're doing the subsidy. So apparently the subsidy is going to bring this down to a reasonable level, and that's going to come out of taxing premiums, which means everybody else's rates are going to go up if you don't qualify for the subsidy. So you've created a cycle that's not sustainable in the long term. So they're going to have to make some tweaks to that piece of the legislation. You might be an actuary if you've concluded you're popular because you talked to someone. I got very fortunate in that the woman I married is social. So when I have to do social stuff, I always bring her with me, and then I don't have to talk that much. Okay, second thing we're going to talk about is this adverse risk component. And this adverse risk component is one that's going to be critical for us as carriers, because if you start losing healthy people or getting more of the sick, what happens to your cost? And the shop exchange, this is real critical. Every big carrier knows that in the face of healthcare restrictions, these are things from consultants. In the face of new health reform restrictions, expect more small employers to offer self-funded health plans. Links network of employer benefits, basically self-funded plans, but more are showing interest since the passage of health reform. Aetna has been tacking on acquisitions this year as it diversifies its operation, including the deal to acquire Prodigy Health to offer small employers self-funded plans. What do you see happening here? Why do you think they're doing this? Pardon? You know something about the industry. Why are they doing this?
There's multiple reasons. So one of the reasons is that under self-funded environment, you can continue to provide percent wellness and create your rate based upon your
population's cost, not everybody else. Exactly.
The other reason, important reason, is that the distribution channel then can receive a compensation other than what's required
for the broker. Okay? I wasn't even going down that one. I was going down the first one. 60 to 70% of the employers that we insure are here. Why? Well, claims don't go to zero. They can't go below zero, and for employers, they're never zero. But you have $1 million claims in groups that are up here. So most employers are down below this number, this index rate. And if you're below this index rate and you can self-fund, what happens to your group? Your cost is less. I'll give you an example. This is an example. This is a 33-employee group, and it would have come in at the teaser, which is for us it was 25% below the index rate. And today, in today's environment, here's what they end up paying, and their premium is $170 per member per month within the group. That's a good premium. It's a reasonably healthy group. Post-reform, that goes to $224.21. Now, if I'm trying to sell to that employer, whether I'm an insurance broker or an insurer, I can now say, hey, you know what? You should self-fund. When you self-fund, that means as a company, you're responsible for your claims cost. You're basically funding an account. We're paying the claims from your account, but you have two things. You have a specific stop loss, meaning if you have a $10,000 claim, say, we'll cover everything above $10,000. And you have an aggregate, meaning if you get $3,000 or $4,000 or $5,000 claims, we'll cover if you have that happen. So what ends up happening to that same employer in a self-funded environment is you come down, actually us as the insurer, we make more money because minimum loss ratio doesn't apply to self-funded business. So we have a higher profit margin. The employer goes through, and their best case, their expected would be $179, only $9 more than they're paying today, well under the reform number of $224. Their best case scenario, though, saves them about $80 per member per month. And their worst case saves them $9 or $11. So every employer that's in that lower band is going to opt out of the shop exchange and say, I'm going to do this. Those employers are the healthier groups, and they're what's holding the rate down in that exchange. So the exchange can't survive because now if you lose a portion of those groups, the rate has to go up because they're the healthier groups. When the rate goes up, more people will save more money by doing this. So you're going to have companies coming up with ways to self-fund employers down to 15 or 20 employees. So here's an example of how that risk selection affects you. Today, If we have a block that's running at $250 per member per month, and the 5% of the healthiest population leave, so 1 out of 20 groups decide to self-fund, well, their cost is only going up $13 for the rest of the block. But 60 to 70% of the groups are at that level. So what happens now, if you lose 10 to 20%, costs are spiraling. More and more groups are going to look at self-funding as a solution, and there's no penalty, because if they have a catastrophic claim and the reinsurer says, do you know what, I'm going to charge you $1 million now to cover you for another year because you got all these really sick people, the group can go into the exchange and get the community rate anyway. So they're basically can bide their time until they have a train wreck, is what we would call it. And in the train wreck, they can go back in the exchange, be there for a couple of years. When the train wreck's fixed, they can opt back out and self-fund again. There's nothing to tie them in. So the problem is you've created an environment which those of you who are statisticians, you'd call gaming. You've created an environment where there's gaming. People are going to make the decision that's going to be serve their interest best. And in this piece of reform, you've created an environment where those who game come out way ahead, and those who don't have that ability because they have the high cost end up paying the price. And so those rate bands don't apply anymore. The whole block starts to deteriorate. Then those employers will just opt out altogether, send their people to the exchange, and those people in the exchange will drive the cost up in the exchange. So you've created a no protection for people moving in and out of the various systems. And you have to do that to have a viable health insurance model. Think of it in terms of life insurance. If you had guarantee issue life insurance, when somebody gets diagnosed with cancer, they go buy $5 million in life insurance. When they're cured, they term it. You could never price that correctly unless you're charging $5 million. You get the opposite. You get the exact same thing if you get the sickest population, just at a different level. So if we had the 5%, if our 5% of our sickest members are in there, and that goes to 6, because some of these other people are opting out, our costs go up again. So when you do community rating, the reason they had rate bands before is so that carriers don't have to balance that risk mix, because there was nothing to guarantee people in the system. The state that has the most extensive community rating model, which is a 4-to-1 if I remember correctly, it might even be 5-to-1, is Massachusetts. They also have an exchange. They have the highest premiums in the country, and their premiums are higher because of this whole selection curve. The penalty to get people in the market isn't worth the premium. For our 14,000 employees, we could send them all to the exchange, pay the penalty, save money, still contribute several $1,000s a year towards their family coverage, and those who make $12 an hour are getting subsidized by the government to boot. They would be better off, we would be better off. Most employers are going to do that same math. And you've already heard some of the companies like Caterpillar and John Deere say, yeah, I don't know why we wouldn't send everybody into the exchange. It reduces their liability, and at the same time funnels the pool, but then the healthy people get the option of opting out. You might be an actuary if your wife has insomnia, so she rolls over and says, tell me again, darling, what do you do for a living? This has actually happened in my house. So, second piece of this reform that makes things difficult on the carrier side. If the risk selection is not enough, it's the minimum loss ratio requirements. There's nothing wrong with minimum loss ratio requirements. As a matter of fact, states have them. The issue is the distribution system. If these minimum requirements were put in place for 2014, not one carrier would be complaining, because exchanges always run higher. It's a more efficient delivery system, and the cost structure is significantly less. That actually, my understanding was, this was the last one I could find on paper, was 2009, but 2010 I believe ran at 92. So at a 92% loss ratio, a minimum loss ratio of 80% is irrelevant. The issue today is we don't have that distribution system. And I think there was a political reason this was passed, and I won't get into that. But the rules were set in November, and carriers already had all of their premiums set for the next year, and because your rates are guaranteed for a year. And so what happens is they set the rule, and then you're going, okay, we're not going to meet the minimum for individual. The reason you're not going to meet the minimum for individual is we have a distribution system that's driven by brokers, underwriting, medical expense. Under a minimum loss ratio, so you're probably going, well, you're not that smart a guy. Look, you're still selling in Georgia and you're losing 5%. But under minimum loss ratio, we're losing money in most of our markets selling individual today because we don't have an old block of individual. We got into it in 2006, and in 2006, we were still in that medical underwritten curve, and the brokers get a bigger piece. If you go to an IHC or a Blue Cross that have been selling it for 20 years, they're already at the 80%. The carriers that are newer have a lower loss ratio because the premiums are lower. So for us, in most of our markets, we've got to make a decision as to whether we're going to keep selling individual in there or not. And what will end up happening for us and many, many other carriers is they're going to have to evaluate their cost structure, how they're going to do in an exchange, and if you're not going to be strong in the exchange, you're going to pull out of those states. So we're wrestling with which states to pull out of and when. It's going to all come down to cost structure and how big you think you can be. In an exchange environment, if you think about this risk selection curve we talked about, what's going to end up happening is if you can't be big, you're not going to be in at all. So most markets, you're going to have fewer carriers than you have today. Probably not in Utah because there's really only 3 or 4 in Utah today. But we have a lot of markets where there's 10, 11 players, and you'll probably be down to 3 or 4. Now, one of the big differences, and this is where you have some real success, is you're changing the distribution cost for the product. Here's the cost today. 75% MLR. This is the claims component of what we pay. 9% for individual goes to broker. That may seem like a lot, but remember the average premium is around $100. In Georgia, for example, it's $108. Here it's about $150. You've got all your underwriting, all of your pre-existing administration for people who didn't have prior coverage, all those things going on. And then you've got the collection. We're collecting from each member individually. So we've got a whole lot of members, and we got to go to each one of them to get the premium. They're late. You send out more notices, things like that. So that's the cost today. Now you come over here into 2014 in an exchange where the premium's coming through the exchange. We don't have to go collect that anymore. We're paid. The government subsidy comes through the exchange. There's no underwriting. Our cost goes down significantly. You have a better value product. And we actually will do better than we do today under reform. But it's a little tricky because if you look at that, you can go, wow, that's a really good deal. And it is a good deal because you're spending more on healthcare dollar and quality. The problem is the rate's different too. So here's what you're spending today. Here's what you're spending tomorrow. So you're going to have a significantly higher cost with the product, which is one reason those percents are smaller. And that's something that if you're going to insure everybody in the country, you're going to have to pay for it somewhere. And so it's a reality. You might be an actuary if your personality is the only contraceptive you need. Okay, so what's going to create these risk problems we have, and how are they going to get addressed? We have a lot of ways that risks get adjusted. Carriers have used risk for years to get favorable risk to make more money, or to get adverse risk and go out of business. So you're always trying to balance those differences. And the balance is huge. Number of specialists you have. There's a lot of studies that show the more specialists you have in your network, the more specialty cost you have. It's not even related to access. It's if you have 3 orthopedic surgeons and you add a 4th, cost and utilization go up, even if it's the same population. There have been a number of studies to illustrate that. Same thing with radiology, MRIs, PET scans. But how many you have drives your risk. People who have a chronic condition have a different priority than people who don't. If you have not been to the doctor for 2 years and you're picking a health insurance plan to avoid paying a penalty, you're going to find the cheapest plan that's out there, the least expensive plan. And you're going to select it because it saves you $8 or $12 or $20 a month. If you have a chronic condition, you're looking for the product that has the doctors that treat your condition in it. So while there's access standards for things like Medicare, nothing is defined yet for the exchange. They're going to have to define that. We're moving ahead as if they're doing Medicare standards, but if they don't define it, somebody could set up a plan in Salt Lake with one cardiovascular surgeon who doesn't speak English and one orthopedic surgeon who works on Saturday. and that becomes a network. So you've got to have minimum requirements. But people who exceed that are at risk for adverse risk. And I'll give you an example. If you have the Huntsman Cancer Center in your network, you're going to have more cancer patients than somebody who doesn't. And you've got to have a way to adjust for that. And that's difficult to do in a community-rated environment. Same thing's true with hospitals, marketing materials. You can do materials that appeal to the younger population. They do that with Medicare all the time. You know, sneakers for health programs that people who are 66 like and people who are 90 don't. And so you attract a healthier mix of member. Travel distance, your product design, those are going to be pretty much defined. But the thing to remember is you can sell outside of the exchange. So product design. Age rating slope has been done in the past because you want to be precise. We had, for our stuff that sold online, our loss ratio was 8% worse than our medical loss ratio was for stuff that was sold through a broker. We couldn't figure out why that would be. I mean, you think about it, people are buying online. I assumed, incorrectly, you know what, more people lie about their health status when they fill out the applications online. That wasn't it. By the time we drilled down, what we found out is when they're shopping online, they are comparing you to everybody else. And if you have one rate cell that's underpriced a little bit, everybody buys it. And the whole difference, that whole 8 to 9% difference, was because we had two rate cells that were just a few dollars off for that particular market. And so going to a 3-to-1 age slope, you minimize that on both ends of the curve, but it becomes more important in the middle of the curve. Level of medical management, you use a primary care physician, you require referrals and OS, service levels, disease management programs. If you have really good disease management programs, you can keep people who are really high cost and really expensive in your plan forever because they like it. It makes them better. So some companies choose not to do disease management programs. Well, today, because you're rating employers, you do it. Because you're trying to improve the health of the employee, you have the group, you want to keep the group. When you're in a community-rated environment, are you going to do that? Some plans may not. So what the feds have said is, well, we're going to help make that transition because nobody knows what risk they're going to get. We're going to do some reinsurance programs. We're going to do a transitional one that will reduce the uncertainty of risk, another one that will do the risk corridors. Those don't matter. They go away in 2 years. It's just to protect you if you screw up day one. But this one, the risk adjustment one, creates a problem for us. And it creates a problem for us because there's no rules defined. So here's what happens. If you go in the exchange and you have the lowest benefit plan they allow, a bronze, and the richest one, a platinum, and you've got both those products out in the market, who picks the richest benefit plan? A lot of studies show you people who have conditions they want to get treated. Either you picked it because, gee, it's open enrollment, I know I screwed my knee up, maybe I'll have the surgery this year, I'm going to take the rich plan so that I don't have the deductible. And if you're not going in, you take this plan and save the money. So what happens is you have a risk selection criteria where you end up with a healthier population here, so you can price it here based on the block average, but the net cost ends up being lower. And you can price this one based on the average, but the net cost ends up being higher. We don't know how they're going to adjust that risk because there's not enough money on the lower premium to offset what you lose on the high premium. If you look at that, you're off, what, $65 there, and you're only saving $35 here. So nobody's defined how that's going to fit together. The second part that's not defined is you have to have claims data to do that. So if I sell this product and my medical loss ratio is below the minimum so that I have to rebate money back to the member because I got a healthier population than I expected, do they come along 6 months later and make me fill in this gap too? And so we're kind of at wit's end on how we're going to address that. But basically, they're going to work through all this. It's a problem. Utah has an exchange, those of you who know it. Their risk adjuster doesn't work either. Nobody's got a good one in an exchange. It just doesn't exist. So as we work through that, that's some of the things you have to solve to level the playing field. But the difficult part is how you're going to get the money and reallocate it because the premium isn't there. The big open issues, I'll skip that. You might be an actuary if, instead of getting slapped in the face for getting fresh with your date, she slaps you because she's afraid you're dead. So there's a couple things I want to talk about real quick. Actuarial science, I've loved it. I got into it. I liked it. I wanted to get in healthcare. And back in the mid 80s, people were shying away from it because they thought reform was going to go to single payer or something. They haven't done that. But the market's changed. What used to be important as an actuary, if you look at this environment with community rating, you look at this environment, about half the functions that actuaries do today go away in healthcare. About half. And what we're doing as a company, we have 83 actuaries. We're actually loading up on what we call medical economics people. People who understand medical jargon and know statistics and know programming. It's a big field. We'll have far more of those than we'll have actuaries. Why? Well, when you look at a community rate, you have one option to be competitive with everybody else. Cost. You've got one rate out there, and anything that changes on your cost, you want to find it quicker than your competitor does. That's the only way you're going to solve and address your problems. So we're hiring medical economics people. We can't even find good medical economics people, which for us is somebody who can program SAS, program SQL, and understand statistics and basically logic thinking. And we can't find enough of them because they're not out there. We have actuaries, but actuaries, they didn't get into the business to do medical economics. They want to forecast stuff. I mean, you guys probably don't even know. I became an actuary because, A, I like the challenges of it, and B, I decided if I was wrong, they won't know about it for 5 years. So I was in good shape. Worst case, you move every 4 or 5 years, right? So med econ is more immediate. You're using statistical tools to find out where those variations in cost are and what's changed. And so for us, that's the big thing that's missing, because we've got plans all over the country, and we've got to try and figure out how we're going to measure that cost and how we're going to find it quicker than our competitor and where it is. And it's easy when you think about it in terms of a database they give you in school. But when you actually look at the data and you find out that you've got 27 hospitals in your system and you've got some low volume ones and some high volume ones, and a certain procedure is now costing you significantly more than it used to, and you adjust it for case mix and things like that, what's the driver and how do you control it? And so for us, the big issue is to be competitive in a community rated environment as a carrier, you have to get average risk or better, and you have to have a cost structure that can compete with your competitors. So that's the goal right now today. The actuarial jobs, there's a little bit of work there. There's a lot of work filing with states. Our regulatory stuff has gone up 3 times over what it was just a year and a half ago. And so we're doing a lot more filings. We have to submit a lot more data. We have to do a lot more analysis for federal and state agencies. But once we hit this community rated model, a lot of the things that actuaries were critical for, and I don't want to discourage people from going into the field for healthcare, because you're still going to have half the stuff you have today, but a lot of the stuff that is critical if you're an actuary goes away. A lot of the fun stuff. You're still doing IBNR, but selection curves are gone. You're still doing pricing, but a lot of the strategic side of pricing is how I'm going to get a better price on a benefit that attracts and is attractive to consumers goes away because the plan designs are defined. So some of you probably have to go to class, but if you have questions, I'll take those. Happy to take them. Yes?
So if I can understand with the ASO situation, anybody who's below average in their company's healthcare costs are going to move that route, right?
Yes. That would be, I wouldn't say anybody, but I would say a high % of employers will, and that will move the average up, which means more people now will.
So it may actually be the majority go that route, because if it moves those costs up, it'll be the most expensive, 20% are on the exchanges, and the other 80% can't afford to go over the ASO.
Yes.
And that really does bring actuaries back into the table, because
On the ASO side, in a reinsurance model, it would. And we do own a reinsurance company, and we do that. But that's much simpler to do reinsurance than it is to price small group products.
Sure. But okay. But you're selling reinsurance to the company.
Yes.
And so you get to avoid a lot of the regulations because you're insuring the company.
You avoid all the regulations. That's why everybody's going to go that route. And everybody knows it but HHS. And they know it now. but they don't have a solution because you have two federal laws, one that creates the opportunity and one that gets destroyed by it.
So you made one other comment that I didn't understand is you used Caterpillar as an example that they, something about paying some penalty. I guess
If you're a large employer under the current bill, if you don't cover your employees, you have to pay a penalty of, I think it's around $1,500 or something, $2,000. $2,000 penalty per employee. But most of those employers, when you're talking like a company like Caterpillar, their benefits cost $7,000, $8,000 a year for that same employee. So for them, it's cheaper to pay the penalty, send them to the exchange.
what were they doing before? Nothing?
They're covering them today as a group. It's part of the group policy today.
They're not an ASO.
They're not, even if they're ASO, they still have to pay the penalty. And remember, the big issue here, the big issue is a group like Caterpillar that's union driven, has an older population. They're going to save money when it's subsidized in the exchange.
So you can have half your employees on the ASO and the other half pop it over if they get unhealthy?
You have to have it by your group, but you can break a group up as, here's the manufacturers, here's the distribution arm. I know you guys have class. Anything? Yes?
So does every country have, is this a uniquely American problem that we have?
We have the most screwed up healthcare system in the world. We have great life expectancy relative to our health status. We cure cancer better than anybody else, and if you get involved in an auto accident, you're far better off here than anywhere else in the world. But we pay about 40% more than the rest of the world for it.
Can you outline what we can do? Like an ideal situation?
I gave Governor Huntsman a paper that had 22 things you could do to cut healthcare costs by 25%. And there's way too much to get into here. But you do have to streamline distribution. You do have to solve. We do everything. We spend more money in the last 6 months of life in this country than most countries do in the last 5 years of life. And Utah's the exception, by the way. Utah's the lowest in the country by far. But as you go into the Northeast, we spend a ton of money there. We also push the envelope at every facility because they're getting billed charges. So at Altius, we had 5 children with hypoplastic left heart, which is terminal generally. And we spent over $5 million on those 5 kids, and they all died within 6 months. Now, other countries, you do that at one facility, and when you figure out how to make it work, then you export it to other facilities. We don't do that here. So we did it here. They do it in San Francisco, LA. Everybody does the same thing with the same outcome because they can charge for it. So it's just a different structure. I will also add, though, most medical technology improvements are developed because of this country. When you ration the care, you don't push the envelope, you don't improve it. And most of the development, you look at all the biologics. They've got biologics now. If you get a certain type of tumor in your lung, they can inject this drug, and it will go and it will consume. The cells will be consumed, and then those cells that they inserted starve to death. And it's in testing right now. It's about a 20% cure rate, but it's magical. But you wouldn't have that if they couldn't charge $80,000 for it either. So there's a balance. Our country invests in most of the research, most of the development of new technology for the world health system comes out of our country. It may be developed in Germany, but they're still developing it to sell it here. So it is a balancing act. So if you want to do the best thing today, you can cut it 20% if you eliminate obesity and nobody smokes. But Social Security costs will go up through the roof because now they all live longer. So it's balancing act. Thank you, guys. I appreciate it.